Thank you so much, Sabina. And I have to say, first of all, it's so exciting to see so many people in the room. I had no idea, would people be like, that's an obscure little offshoot, or would they be interested? So I'm really thrilled to see that people are interested in design as applied in healthcare. As Sabina said, I'm actually, I'm not a designer, so I'm nervously speaking to a room full of designers about how much of an impact, how and why we've brought design into the work that we're doing. So hopefully you'll enjoy hearing it from a non-designer, what it's like to work with you guys. As Sabina said, I work at the Mater Hospital in Dublin, so it's just to give you a kind of sense of context. So it's in the north inner city. It would be kind of a largely, I suppose, underprivileged area. So we'd have a wide demographic, but I think it's probably the oldest and the most socially disadvantaged hospital in the country. So there's a staff of 4,000 to give you a sense of scale, and it's rapidly growing. I think we'll be at 4,500 within a year or so. So the unit that I work in is called Matter Transformation. It was started up about 10 years ago. It's pretty unique. It's essentially a team of people with different backgrounds that are there to work closely with frontline staff to help them to improve the services that they deliver. So there would be some people that have like Lean Six Sigma backgrounds, there's data people, and then there's a lot of like clinical people like me. I was originally a speech therapist that just became really interested in trying to improve the systems around them. And over the 10 years, we've sort of evolved and sort of found our way to a model that we now use for helping people, and design has become a core part of that model. So I'm basically going to get right into it and talk about the case studies. So just to give you, I suppose, really frame it for you, everything that we're doing is a response to a problem that we're seeing on the front line of healthcare, and then we're working very much down in the weeds with staff, with patients to try and solve problems. So stroke link, this problem, so two of the consultants, stroke consultants came to us. I'm just going to, the timer doesn't seem to have started, just to flag it for you, sorry. Thanks. I won't take extra time, don't worry. So two of the stroke consultants came to us a few years ago, 2016 it was. We run this design week every year, which I'll tell you a little bit more about in a moment. And they proposed this challenge. And what they said was, despite everything that we do, so when a patient comes into the hospital and they've had their first stroke, before they go home, it's really important that we tell them how to prevent another stroke. So they need to monitor their blood pressure, take certain medications, make lifestyle changes, and so on. And they described to us how, despite the best efforts of the team, and the really genuine best efforts of the team, and I was part of that team at one stage, so I knew it was true that we did try to educate people before they went home, that patients would repeatedly come back in for their 3-month appointment and say, nobody told me I was supposed to take that. I thought I only had to take it for a while, or I didn't know I was supposed to make those changes. They hadn't gone to their GP, and so on. And really sadly, 20% of people who have a stroke are likely to have another stroke within 2 years, and many of those second strokes are either debilitating or they can be fatal. So what we did initially was we put the challenge to our design week. So next week, actually, we will be running our 9th annual design week at the hospital. So this is a collaboration between the hospital and the National College of Art and Design, NCAD, in Dublin. And basically, we set up a studio in the hospital. We invite the design students from 3 different master's programs, service design, interaction design, and medical device design, into the hospital, and we give them a range of challenges that the staff have put forward. So it's a really fun, really fast-paced week, and they basically get immersed right in. We bring them up to the wards, meet patients, meet staff. So we took this challenge to Design Week, and what we found is that we were really only beginning to sort of scratch the itch, that we needed to get much deeper into it. It gave us really good insights, but we were like, we need to get fully into this problem. We can't solve it in a week. So we sourced funding from Sláinte Care initially, which is a government initiative to transform healthcare services in Ireland. And that enabled us to recruit 2 nurses. And also critically, we recruited an interaction service designer. And essentially what we got that designer, Alan, to do was to begin with really, really deep research. So starting right at the beginning of the journey after a stroke, and meet people literally up on the wards and find out what's going through their heads, what are their information needs, what's going on for them, and so on, right through to the moment of discharge, and then in the sort of days, weeks, and months later, what's going on for them. And this sort of threw up really, really great insights. Like, for example, the day before a person goes home after a stroke, they typically are worried about whether there's going to be somebody there when they get home, and what happens if they fall on the floor and have another stroke when they get there. And beyond that, they can't really process a lot. So we moved away from the tradition of basically loading a whole load of information on them the day before they go home, and instead the stroke link nurse would meet with the patient, just sort of develop a little bit of rapport and say, don't be worrying about anything, I'm going to ring you tomorrow to check in, and then I'm going to come out to the house in a week's time. So then with this sort of information, what the designer basically worked with the nurses, with the consultant, and with the wider team to sort of work through a new service blueprint, and sort of decide, okay, well, what exactly what information will we give them at what time, critically, and in what format. And about a year later, we basically had a really carefully, thoughtfully designed book. Everybody thought we were going to do an app in the beginning, but we didn't. We did a book, and that's what people wanted. And that's what people now cling to. We also had some really pared back digital elements, like a texting, which we're really only prototyping at the moment. We're not convinced it's a core part of the service. Just little reminders. Did you pick up the blood pressure machine? Here's the video on how to do that. And we're actually about to launch a website. But to be honest, the critical elements in the first few years were that carefully designed nurse service along with the book. And basically, we are starting to show some incredible changes in things that are traditionally really hard to tackle in healthcare. So the patient experience, you can see the scores jumped right up afterwards. And then also in affecting positive behaviour change, which is the really, really difficult thing to do. It's sort of a perennial problem in healthcare where we provide lots of information to people and then we can't figure out why they're not following it. So we started to see some really, really exciting changes there. We're still at the early stages. This is from our, I'd say the first, I think it's 6 months. And we're now going to enter a phase where we collect much larger scale data, which will hopefully become publishable and really start to spread the message, not just about this service, but about this approach to designing a service. I'm a little bit behind time, so I'm going to skip through these, but basically starting to see real effects in terms of patients not turning up at the A&E in crisis or in confusion after their first stroke.
I had a history of hypertension, and when I come home, I was given the booklet, and I have a BP machine, and I was recording my own BP daily. So all my questions were answered clearly. I had my follow-up with Professor Murphy, and I was discharged. And he was very happy with me and said to me, "Now, sister, I don't want to see you again." I said, "That's mutual, I don't want to see you." And since then, I've just kept going.
So that was StrokeLink, and I think that was probably our first really, really big win in applying design to really tackle a long-standing problem in healthcare. I like to use that example because I think it helps people to get it quickly, what we're actually doing. But a sort of word of caution, I suppose, about that one is we had the ideal situation there. We were about to develop a new service. We had new staff. So we weren't trying to change an existing system. And also, it was a relatively discrete service. So, of course, it was sort of intertwined with the hospital services and with the community services, but only to a limited degree. It wasn't sort of messy intertwined with those. So it did make it a little bit easier. So I want to show you a second example that we're currently working on. And one of the volunteers in the room, Linda at the back, works with us in matter transformation, and actually she's done all of this, so I'm going to stand up here and talk about it, but it's mostly Linda. So Skinnovate is basically a much messier one, and I think it's just really important to be honest about that context and give people a sense of how we deal with this when it starts to get messy and complicated. So 45,000 people in Ireland are currently waiting to see a dermatologist. Mightn't sound alarming, but there's only a population of about 5 million, so it is pretty bad. And at the Mater Hospital, the situation was no different. There was almost 4,000 patients waiting on the waiting list, and it was growing. We could see the projection. It was quite frightening. I think one of the consultants at the time described it to us as it's like being under a tsunami of referrals. And given that a lot of those patients have potential skin cancers, that's quite a frightening situation to be in for them, not to mind the patients. So this is sort of an analysis of the waiting list. I almost want to show this as well, to show like the world that we were in before we started to bring in design is deeply based in data. So everything that we do is very much data based. And I think our coming together with design then is a potentially very powerful thing, because I think sometimes that's what can be missing in the design world. But basically this was an analysis of our data at the time, and essentially the situation was that patients were waiting who had urgent referrals, so potential skin cancers for the most part, were waiting an increasing amount of time. I think it had hit an average of 81 days by the time we came in. And then you can imagine then those who had things like psoriasis or eczema, these conditions that are not urgent but still very much affecting people's quality of life, they essentially weren't getting appointments. So things were in a pretty bad situation. So the process that we worked through, and I'm going to talk you through the sort of before we brought the designers in first. So what we start off with is we would do a lot of one-to-one interviews with the staff, and we deliberately do it one-to-one so people can kind of be put at ease and talk honestly and build rapport and so on. And then we start doing really deep systems data analysis. So we would use a lot of Lean Six Sigma in the approach, but it's very, very data-driven. And then we bring the whole team together, so they'll cancel their clinics and their surgeries and so on. In this case, it was actually three full days with the full team, and we work through that data. And the data is quantitative but also qualitative. And then basically we help them to build a roadmap for change and then start to meet them at 30 days, 60 days, 90 days to see if it's working. And then we implemented those changes over a period of about 12 months. So this is sort of the world that we were in before the design, and it looks a bit designy with the post-its and bringing people together and all of that, but essentially this is very heavily process focused. So you're bringing people together and getting them to sort of look objectively at what's happening in the system. And there's something really important. So we use a lot of tools that you'd be familiar with, where we're trying to create equal voice in the room and trying to help people to co-design the roadmap for change. So that all feels very familiar, but it is very much focused on this sort of nice objective thing over there, the process and the system. But what it's very powerful at doing is bringing the voices together to create a sort of unified vision for where the problem is. And that in turn helps them to sort of get past their differences and hierarchies and start to come up with kind of real and tangible results. So the kind of analysis that we'd be getting excited about would be, so this, for example, in this particular case with dermatology, we could see that certain consultants were just getting a lot more referrals. Basically, their name was known, so the GP would say, oh, I know Patsy Lenan, I'm going to refer you in, having no idea that her list is way longer than somebody else's. And then what would happen is, if you were an urgent case on that person's list, you were going to end up waiting longer. And if you were a routine case, you had no hope of ever being seen. So this helped to illuminate that, and that helped the consultants really objectively look at this. You couldn't say anything but we need to move to a centralised system. Which is what we did. That was one of the key changes. There was lots of other changes that they agreed to, like bringing in nurse-led clinics, a number of other different process changes. And basically, it achieved a 40% reduction in the waiting list over a 9-month period. And that has been sustained a couple of years later, which is the critical part. And that's because people were really invested in the solutions and really felt part of them. But, and this is where the design bit came in. And when I say design, there would have been a slight designy focus within that, but when we went really kind of exclusively into a service design approach, basically we could see through projection analysis that we were headed right back to where we were. So basically skin cancer is supposed to either double or treble within the next 10 to 20 years, depending on what report that you read. So our referral rate was escalating. And then also we have an aging population. So basically we did some projection analysis and said within years we're going to be back to the numbers that we were originally at. So we have to do something bigger, and we have to do something across the system. We could see from an audit that about 30% of the referrals that were coming into the hospital could potentially, or in theory, be seen by a GP, a general practitioner in the community. But for some reason, they were all getting sent into the hospital. So we did a little bit of analysis on this, just talking to people, basically. And there was two big things. They said, number one, dermatology is poorly taught. That's an international thing. So for whatever, well, not for whatever reason, one of the critical reasons is that it's a really visual and tactile field. So it's very hard to teach it through the traditional ways. Textbooks, even with photos, VR, anything is not going to cut it. So it tends to sort of get sidelined in the programme, and people are dependent on what they happen to come across when they're on placements. So basically, a lot of GPs will agree that they don't really feel very confident in the management of skin conditions. So when in doubt, they'll refer in. And then the other big problem that we could see is that they only had one option. I'm not saying this is internationally the case, but certainly in Ireland it would be pretty common that if you want a specialist opinion, you refer in for an outpatient appointment. There's no in between. So we kind of saw these as big sort of system questions that there was no obvious answer to, and we wanted to look at it through a design lens. So the first question that we posed was, how might we change the way dermatology is taught? And we basically connected then the dermatologists with the medical device design group, in particular in NCAD, to do an initial little sort of experiment and see what they would come up with. So essentially what they came up with was a teaching tool that basically there's nothing like this available on the market to our knowledge. A lot of teaching tools that were out there were models, were kind of plastic and just really didn't cut it. And it was that or back to photos. But the dermatologists and the GPs were saying, but you have to feel it. You have to hold it up to the light and see what's going on. So down to the pure, I suppose, craft and then also the design approach of the students at NCAD, they came up with these really, really incredible skin models. And we've been evolving those ever since. You'll see, for example, that they're mostly on very pale skin. So one of the big things that we're trying to do at the moment is to present the conditions in a full range of skin tones. A little bit challenging in the Irish population because a lot of the cases that the designer's naturally seeing have paler skin. And then the skin models replicating these conditions in an incredibly high fidelity way are encompassed in sort of books, each one sort of explaining the differential diagnosis, and then there's a book set. So that's basically getting a huge amount of attention. I was just talking to the dermatologist yesterday, and she's been asked to go to the National GP Trainee Conference and present them. But there's a lot of excitement about this because it's sort of giving people something that's been missing for a long time. So essentially, it's innovating the way dermatology is taught, and that's been completely facilitated through looking at it through a design, more of a product design lens, but through a design lens. And then the second one is, how might we offer GPs alternatives to an outpatient appointment? So to look at this one, what we basically did was we started off in a similar way where we did a number of interviews with GPs, one-on-one, just literally sitting there for as long as they would give us and listening. So what is your working day like? When you get a skin condition, when you refer in, obviously if you're worried about skin cancer, you're going to refer in. But if there's something else, are there some conditions that you feel you could be managing, but you don't because you've no other options? And then they would talk through lots of different case examples. And then from that, we basically started to run workshops with GPs, building up some potential ideas. And then in the last week, Linda was here volunteering at the conference, and I snuck in and was taking photographs of her work. Thank you, Linda. So Linda and another designer, Alan, were actually last week out in a GP surgery to really understand their world. So we had started coming up with some initial ideas like, oh, there's this great app called Silo. It's effectively like WhatsApp, but it's encrypted, so it's safe to use, and we could transfer photos, and this will be amazing. And then they went out, and one of the first things that they discovered was the GP is so pressured, and the way their workflow is that the patient will come in, and when they leave, the GP will turn around to their desktop, and they'll use this rather old and clunky system. They'll have minutes to do this, and then the next patient is going to come in. So the first thing they said was, this has to be on desktop. So that went, either we use Silo on desktop, or we need to find something else that fits in more smoothly with this workflow. Otherwise, they just won't use it. And then the other one that I thought, so the other aspect of the solutions that we're looking at is more on if a consultant does see a patient once and then could discharge out to community quicker rather than holding the care, what would they need? So Linda and the GP basically looked at the current letters that are going out and some prototypes of new potential letters, and they pulled it apart together with her saying exactly what she would need to see in what order and so on so that they can design new letters. And a really critical finding was, I'm receiving up to 30 letters a day. This needs to be simple. And so, of course, the purists in the hospital were wanting to write 3-page to explain. She's like, we're not going to read that. You need to have the highlights up top. So basically, I'm showing you that to kind of show how deep we're trying to get into the local systems to make sure that the solutions that we're developing are based on need and fit the realities that people are in. So this was us working with trying to get trying to get yourself to talk to GPs is really difficult. So we take any opportunity that we can. So there was a bunch of GP trainers in the local area at a meeting, not our typical design workshop type of setup, but we said, who cares, we'll take it. So we came in and we gave them worksheets, and we talked through, and we basically worked through a number of questions with them, saying, like, these are some of the ideas that have been coming up from talking to you. What do you think? And got them to write down all of their thoughts. There was obviously a bit of group discussion, and we basically started to prioritise which ones should we be going after, which ones are going to be the winners. So that's now informing where we're at the moment. So the reason I wanted to show you that is because it's much messier, and also, so it's much messier, but that's where we feel that's why it's working, and that's why there's an awful lot of interest. Is actually, I remember the GPs at the end of that workshop just said to us, this is so refreshing, no one's ever asked us before, which is quite shocking, but it's pervasively true, I would say, across the system. So what we're doing is we're not sort of working at a sort of policy level. There's completely a role for that. We're down in the weeds, listening to what's really happening and trying to apply design in whatever way we can to tackle problems. And I think the important thing, one of the reasons I want to show you that as well, is that we're working within constraints, and we have to a degree accept those constraints. So in the stroke link example, we can be a little bit more purist about it, but in this example, we're working with the system as it is and trying to come up with a new service that meets the needs of that system while solving the problem. The last thing that I wanted to show you is just that I hopefully have conveyed to you a little bit that we don't exclusively use design. We're using design in the context of other methodologies, and we'll use design kind of fluidly with those other methodologies, and we'll use it less and more depending on the particular problem that we're working on. I think that's it. Oh yeah, that was just kind of our reflection on what we think that the different lenses bring to our problem-solving methodology. Okay, that's it. Thank you. I hope I've left enough time. Sorry.